I have a great pleasure to talk today to Professor Georgiosem Romanosem. Hello.
Thank you.
Professor. I would like to ask you a few questions. What rules should we follow to have a success in augmentation procedures?
Are you talking about bone grafting procedures specifically, not soft tissue augmentations? First of all, thank you for this interview. I love your country and the Polish dental organizations. And definitely the most important rules, what we have to follow is the biological rules, the immobilization of the grafting materials to avoid to contaminate the site, and certainly to have a very good supply, blood supply in the recipient, in the site where we grafted the alveolar ridge.
And what do you think about the bone training? You showed the cases that we sometimes we have to make immediate loading, sometimes we have to...
Yeah, all of these techniques which have been used actually for years in Europe have been developed due to my initial studies in Malaysia in monkeys. When we did research on my associate professorship at the University of Frankfurt, and we evaluated the bone after loading implants immediately after surgery. The bone will be trained, the alveolar ridge becomes denser, and the role of this improving density is because we accumulate within the tissue proteins which could be transformed and translated to bone formation, mineralized tissue. So when we want to improve the bone density of the alveolar ridge, we can go to use progressive bone loading, but in the reality, an immediate functional loading is much better. So the main experience we get when we activate our own muscles, even muscle is not mineralized tissue, when we activate our muscles, the muscle fibers become denser. Similar is when we have astronauts who have no any gravity in the space. Due to the lack of the gravity, we lose mineralized tissue, and when we have gravity and loading forces, we increase the bone formation in the long bones or even in the alveolar ridge. In a similar way, when we accumulate, we increase the forces during chewing, we increase the density of the bone in the peri-implant area.
And should the time of the loading be depend on of the material, augmentation material we use?
There is actually not extensive research on this. Definitely what we know is about the original bone. But even if you use grafting material and the grafting material is autogenous bone, the properties are the same. Now, if we use xenografts or allografts or alloplastic materials, we have seen in our observations, but there are no long-term study and clinical validity of this, but at least in my own experience, that xenografts or allografts or alloplastic materials become denser, and in a combination with autogenous bone, we can have a better mineralization of a period of time, and especially crestal bone stability. For me personally, this is the key for success, to avoid to have crestal bone resorption over a period of time. And using the immediate functional loading concept, having other opportunities and requirements, we have the possibility to splint together implants after immobilization of the abutments, and then the alveolar ridge over a period of time becomes stable.
And what we have to remember about when we do blocks from the chin? You mentioned very interesting thing.
Thank you. The studies show and the experience that we need to know the anatomy. And the anatomy shows that we have very often extensive and long and wide branches of the alveolaris inferior, which are located in the anterior part of the mandible, innervating the teeth in these areas. So the incisors and the canines, even the first premolars. So if we don't have these teeth, these branches become atrophic. However, if we have anatomically, in some cases, thick incisive mandibular canals, we can damage these nerves when we harvest bone from the chin, and then the patients can have a discomfort. More important is if we damage this area and we place an implant later on, this can be a problematic area because nerve fibers over a period of time from the distal part, they can proliferate and they can migrate around the implants, and maybe we have tumor formations. I'm talking about neuroma formations, and then at the end we can lose the implants, or we have to remove the implants because patients complain due to the pain. So therefore, knowing the anatomy, analyzing with CBCT, or better also I would say with a Panorex, because if you have a thick nerve, you will see the canal very easily in the panoramic radiograph. If you have a CBCT, the studies show almost 98 to 100% you see these branches. But the question is how thick has to be a branch in order to have this kind of complication.